Welcome back to Teaching Service Hospital Rounds. Today we are talking about diverticulosis. It is one of the most common findings in all of gastroenterology, and one of the most misunderstood. Most residents can define it in a single sentence. Far fewer can explain why the colon herniates exactly where it does, or why the sigmoid takes the brunt of it. So we are going to build the mechanism from the wall of the colon outward. Then we will look at who gets it, where it lives, and what actually happens to the people who have it. We finish with the conversation you will really have at the bedside, what to say, and what the diet evidence honestly supports. We follow one patient the whole way through. Let us get started. Here is our patient. He is a 61-year-old man who comes to clinic for one reason. He wants to schedule his first screening colonoscopy. He feels well. He works. He travels. He has no alarm symptoms. In his own words, he is only here because his wife made the appointment. That is the whole chief complaint. Now keep that in mind for the next 30 minutes, because almost everything we are about to discuss will be discovered in a person who feels completely fine. Diverticulosis is usually a finding, not a complaint. It arrives on a report rather than in a story, and that changes how you talk about it. Let us take his history. Here is what you should be able to do by the end of this video. First, define diverticulosis precisely, and say why a colonic diverticulum is a false diverticulum rather than a true one. Second, explain the anatomic weak point in the colon wall and name the vessel that creates it. Third, describe how abnormal motility and raised intraluminal pressure push the mucosa and submucosa outward through that weak point. Fourth, use the law of Laplace to explain why the sigmoid colon is almost always the site. And fifth, list the risk factors that drive the disease and tie each of them back to a mechanism rather than memorizing them. Continuing. Sixth, quote the prevalence of diverticulosis by age and describe how the left-sided and right-sided patterns differ around the world. Seventh, state what fraction of people with diverticulosis develop bleeding and what fraction develop diverticulitis. Eighth, define symptomatic, uncomplicated diverticular disease, often shortened to SUDD, and separate it from irritable bowel syndrome. Ninth, summarize what the evidence actually shows about a high-fiber diet and about avoiding nuts and seeds. And 10th, counsel a patient who has just been handed a report that says diverticulosis, in words they will actually understand. Now the history. On careful questioning, he is not quite as symptom-free as he first said. For about 2 years he has had crampy discomfort low on the left side of his abdomen. It comes and goes. It is worse when he is bloated, and it eases after a bowel movement. His stools come every 2 to 3 days, and they are hard and small. He strains. He has never seen blood. He has had no fevers, no weight loss, and no vomiting. Write those details down. Every one of them is going to matter later. The pain pattern will become a diagnosis with a name, and the hard, infrequent stool is going to turn out to be part of the mechanism. Next, his past medical history and his medications. He has high blood pressure, treated with lisinopril. He has osteoarthritis of both knees, and for that he takes ibuprofen 2 or 3 times a week, sometimes more after a long day on his feet. He is on no blood thinner, no aspirin, and no steroids. He has never had abdominal surgery, and he has never been hospitalized for an abdominal problem. Now that ibuprofen line is easy to skim past. Hold on to it. Non-steroidal anti-inflammatory drugs sit squarely on the risk factor list for diverticular disease, and they are the one item on his list we can change this afternoon. Now the social and dietary history, which for this particular disease is the history. He has smoked about half a pack of cigarettes a day for 30 years. He drinks 2 glasses of wine most evenings. He has a desk job and does not exercise. His body mass index is 31. He eats red meat most days, and by his own estimate almost no vegetables, no beans, and no whole grains. His father had colon polyps in his 70s, but no colon cancer. Now look at that paragraph again. It is not a social history. It is nearly a complete list of the risk factors we are about to teach, every one of them modifiable but the last. Nothing on that list surprises him, but nobody has ever connected it to his colon. On to the physical exam. His vital signs are normal. He is afebrile. His abdomen is soft. There is no guarding, no rebound, and no rigidity. When I press deeply in the left lower quadrant, there is a little fullness and a vaguely tender cord, but nothing that makes him pull away. Bowel sounds are normal. His rectal exam shows no mass, and stool testing for occult blood is negative. His hemoglobin is normal. In other words, the exam is essentially unremarkable, and that is exactly what you should expect in uncomplicated diverticulosis. If this abdomen were rigid, or he were febrile, we would be telling a completely different story today. So we sent him for the screening colonoscopy, and here is the report. The scope passes to the cecum without difficulty. Throughout the sigmoid and descending colon, The endoscopist sees numerous diverticular orifices, dark round openings sitting between the folds. The mucosa around them is normal. There is no inflammation, no pus, and no bleeding. There are no polyps, and no masses. The impression reads moderate sigmoid diverticulosis, and that single line is where most teaching stops. So now the real work begins. What exactly is that? Why did it happen to this man? And what does it mean for the next 30 years of his life? So what exactly did the endoscopist see? A diverticulum is an acquired herniation of the colonic mucosa and submucosa, pushing outward through the muscular wall of the colon. And critically, it happens in the areas where the vasa recta penetrate that wall. Say vasa recta as vasa recta. Those are the small straight arteries that dive through the muscle to feed the mucosa. Hold on to the word acquired. These are not present at birth. They are built over decades by pressure. Diverticulosis simply means those herniations are present. The plural is diverticula, and the word says nothing about symptoms and nothing about inflammation. Now a word that trips people up on rounds. A true diverticulum contains all layers of the bowel wall: mucosa, submucosa, and muscle. A Meckel diverticulum is the classic example. Say Meckel as Meckel. Colonic diverticula are not like that. They contain only mucosa and submucosa. The muscle layer does not come along. That makes them false diverticula, also called pseudo-diverticula. Say that SUDD diverticula. And this anatomy is not trivia for the boards. It is the whole clinical story. A pouch with no muscle in its wall is thin. It cannot contract. It cannot empty itself. And thin walls tear and bleed. So when someone says diverticulum on rounds, your first question should be which kind. Before we go further, let us fix the vocabulary, because these words get used interchangeably on rounds and they should not be. Diverticulosis means the pouches exist, nothing more. Diverticular disease is the umbrella term for when those pouches cause a problem. Symptomatic uncomplicated diverticular disease, or SUD, means symptoms without inflammation. Diverticulitis means a pouch has become inflamed or infected. And diverticular hemorrhage means one of them has bled. Notice that only the first word describes anatomy. The other four describe what that anatomy is doing to the patient. Our patient today sits on the very first rung. How does diverticulosis usually come to light? Most often exactly the way it did here, incidentally, on a colonoscopy done for screening. Computed tomography of the abdomen is the second common route. A scan ordered for something else shows scattered outpouchings along the sigmoid. Barium enema will show them beautifully too, though it is rarely used now. There is no blood test for diverticulosis, no inflammatory marker, and no imaging finding you should go chasing. So the point worth remembering is this: we almost never look for it, we find it. Which means the finding usually arrives without a symptom attached to it, which is exactly why the counseling matters here far more than the workup does. Let us build the mechanism, and we start with normal anatomy. Look at this cross-section of the colon wall. From the inside out, first the mucosa, the lining that faces the stool. Then the submucosa, a connective tissue layer that carries the blood vessels. Then the muscularis propria, which has an inner circular layer and an outer longitudinal layer. And here is the colon-specific detail. That outer longitudinal layer is not a complete sheet the way it is in the small bowel. It is gathered into 3 thick bands called the tinea coli. Say that tinea coli, and then the serosa on the outside. Hold those layers in your head, because in 2 slides, only 2 of them are going to make it through the wall. Now the key anatomic fact. Blood for the mucosa cannot come from inside the lumen. It has to cross the muscle. Follow the arteries in this drawing. The vasa recta arise on the mesenteric side and penetrate the circular muscle layer to reach the submucosa. Every single place a vessel crosses is a small defect in that muscle, a gap. Now notice where those gaps sit. They line up in 4 rows around the circumference, 2 rows on each side, between the mesenteric tinea and each of the 2 antimesenteric tinea. The strip of wall between the 2 antimesenteric bands has no penetrating vessels, so it has no gaps, and it stays clear of diverticula. Now watch what happens under pressure. Here is the wall again with one of those vascular gaps. When the pressure inside the lumen rises, the mucosa and submucosa are pushed hard against that weak spot. They have nowhere to go but outward, and they slide through the gap alongside the vessel. Notice carefully that the muscle layer does not follow. It is only the lining that herniates. The result is a flask-shaped pouch sitting outside the muscular wall, with a narrow neck, covered by serosa and a whisper of connective tissue. That is a colonic diverticulum, and now you can see why we call it false. And notice the neck of the pouch is narrow, so it cannot empty itself well. Hold on to that for the diverticulitis lecture. Here is the consequence people forget. The diverticulum forms at the exact spot the artery uses, so the vessel does not get pushed aside. It gets carried along. Look at this dome. The vasa recta drapes right over the top of the pouch, separated from the lumen of the colon by nothing but thin mucosa. Over years, that vessel is stretched across the dome. It thins on the luminal side, and it becomes vulnerable to injury. So this one picture explains both halves of the disease. It is the anatomy of the pouch, and it is the anatomy of diverticular bleeding, an artery lying on a thin dome with stool passing by. It is arterial, and it can be brisk. So where does all this pressure come from? The colon does not squeeze like a tube of toothpaste. It contracts in rings, and those rings divide the lumen into short closed compartments. That is called segmentation. Follow the diagram. When two contraction rings close at once, the stool between them is trapped in a small sealed chamber. The muscle keeps contracting against a closed space, and the pressure inside that chamber climbs steeply. In a healthy colon, these waves are coordinated and brief. In diverticular disease, they are exaggerated and poorly coordinated, and that is exactly what we mean by abnormal motility. Think of it as a row of small pressure chambers, rather than one long moving column. Now the question that separates a good answer from a great one. Why the sigmoid? The answer is the law of Laplace. Say it Laplace. For a cylinder, wall tension equals pressure times radius. Rearrange that, and pressure equals tension divided by radius. Look at the two circles here. The cecum is the widest part of the colon. The sigmoid is the narrowest segment. So for the very same muscular contraction, the same wall tension, the narrow sigmoid generates a far higher intraluminal pressure than the wide cecum ever does. Small radius, big pressure. That is why the sigmoid herniates first, and why 90% of this disease lives on the left. There is a third ingredient, and that is the wall itself changing with age. Elastin is deposited in the tinea coli. The bands shorten, and the colon concertinas like a folded accordion, which crowds the folds together and narrows the lumen even further. Collagen cross-linking increases as well, so the wall becomes stiffer and less able to give under load. Pathologists call that thickened, shortened sigmoid myochosis coli. Say it myochosis. Now put all three together: a stiffer wall, a narrower tube, and stronger segmenting contractions. Age is not a bystander in this disease. Age is a mechanism, which is why this is a disease of the 7th and 8th decades, and not the 3rd. Now let us connect diet to physics. A high-fiber diet holds water and produces a bulky soft stool. A bulky stool keeps the lumen wide, and by Laplace, a wide lumen keeps segmentation pressures low. Now take the fiber away. The stool becomes small and hard. The lumen narrows down around it. The colon has to segment harder and for longer to move it along, and every one of those closed compartments now generates a higher pressure. So low fiber and chronic constipation are not simply associations on a list you memorize. They are the direct input to the pressure equation we just wrote on the last slide. Change the stool and you change the radius. Change the radius and you change the pressure. That is the whole chain. Let us assemble the whole cascade. Follow the arrows. On the left, low fiber intake and constipation give us a small hard stool. That narrows the lumen. In the middle, exaggerated segmenting contractions close off short compartments, and by Laplace, the narrow sigmoid converts that same contraction into very high pressure. Meanwhile, the aging wall stiffens and shortens. On the right, that pressure goes looking for the weakest point in the wall, and it finds the gap where the vasa recta crosses the muscle. Mucosa and submucosa herniate through it, and a diverticulum is born. Every arrow on this slide is something you can name at the bedside. Now the epidemiology, and these are the numbers to carry with you. Diverticulosis is overwhelmingly a disease of aging. Look at the chart. Under the age of 40, the prevalence is about 10%. Over the age of 80, it is reported at 50 to 66%. So somewhere between half and 2/3 of the oldest patients on your service have these pouches in their colon right now. Most of them do not know it, and most of them never will. That is worth pausing on when you are reading a computed tomography report. Finding diverticulosis in an 80-year-old is close to finding gray hair. At 61, our own patient sits on the steep part of that curve. Where in the colon do these pouches actually live? In Western populations, about 90% are on the left side, and most of those are in the sigmoid, which is exactly what the law of Laplace predicted for us. Right-sided disease is very much the minority. But now look at the second bar. In Asia, the pattern flips completely. 75 to 85% of diverticula are right-sided, and that geographic difference matters at the bedside. A patient of Asian ancestry with right lower quadrant pain and a fever may have right-sided diverticular disease rather than appendicitis. Do not anchor on the left side just because your textbook did. Let us go through the risk factors, starting with the ones that come straight through the gut. A low-fiber diet is the classic driver. Chronic constipation is on the list, which fits the mechanism we just built. And hired meat consumption is associated with diverticular disease as well. Now look back at our patient. He eats red meat most days, almost no vegetables, no beans, and no whole grains. And he moves his bowels every 2 to 3 days with hard stool and straining. He has all three. And notice something important. All three of these are modifiable. They are also the three he is least likely to have been asked about. Now the rest of the list. Obesity, smoking, physical inactivity, alcohol, and non-steroidal anti-inflammatory drugs, the NSAIDs. Say that NSAIDs, and then the one nobody can change, increasing age. Return to our patient one more time. His body mass index is 31. He has smoked half a pack a day for 30 years. He has a desk job and does not exercise. He drinks 2 glasses of wine most nights, and he takes ibuprofen 2 or 3 times a week for his knees. He is 61 years old. He checks every single box on this slide, which means almost everything driving his colon is something we can work on. And that right there is the difference between a risk list and a treatment plan. Here is his risk profile laid out against the full list. Low-fiber diet, yes. Chronic constipation, yes. Obesity, yes. Smoking, yes. Physical inactivity, yes. Alcohol, yes. Non-steroidal anti-inflammatory drugs, yes. Red meat, yes. Advancing age, yes. That is 9 for 9. Now this is worth pausing on for a moment. We did not order a single test to build this table. There is no laboratory value on it and no imaging. Every row came out of the history we took in clinic. And that is the teaching point. The story tells you why this colon looks the way it does long before the scope ever goes in. Now the question your patient is actually going to ask you, "Doctor, is this dangerous?" And here is the honest answer. The great majority of people with diverticulosis stay completely without symptoms. For most people, these pouches are a structural feature of an aging colon and nothing more. They do not turn into cancer. They do not require surveillance of their own, and the pouches themselves do not need any treatment. That reassurance is genuinely the single most valuable thing you can hand a patient in this conversation. But a minority of people do run into trouble. So let us put real numbers on that before we promise anything. Here are the numbers. Of people who have diverticulosis, 5 to 15% will develop diverticular hemorrhage, that is bleeding from one of the pouches, and 10 to 25% will develop diverticulitis, inflammation or infection of a pouch. Look at the chart and notice the shape of it. Even taking the high end of both ranges, the large majority of people with diverticulosis never have either event. So the message to your patient is calibrated reassurance, not a blanket promise and not a warning. The risk is real, it is not zero, and it is still a minority outcome. And remember, these are risks across a lifetime in a very common condition. So in absolute numbers, you will still see plenty of both. A word about the bleeding, and we will keep it brief because it has its own lecture. Remember the anatomy from a few slides back. An artery draped over a thin-walled dome. When that vessel gives way, the patient has painless hematochezia. Say that hemato-KZHA, bright red or maroon blood per rectum, with no abdominal pain and no fever. That painless part is the whole clue. This is not diverticulitis. It is arterial, so it can be large volume, and it can drop the hemoglobin fast, but it stops on its own in the majority of cases. Here is the twist. Although most diverticula are left-sided, a disproportionate share of the bleeding comes from the right colon, and the other complication is diverticulitis, which we cover fully in its own video. For today, just place it correctly on the map. Diverticulitis begins when a single diverticulum becomes obstructed and inflamed, and the patient in front of you looks entirely different from ours. Left lower quadrant pain that stays and does not come and go, fever, and a raised white count. The contrast is the whole lesson on this slide. Diverticulosis is quiet and structural. Diverticulitis is loud and acute. Same pouches, same colon, completely different clinical problem, and completely different management. If your patient is febrile with focal tenderness, you have left this lecture and walked into that one. Now back to our patient and his crampy left-sided pain. There is a category for exactly this. Symptomatic uncomplicated diverticular disease, abbreviated SUDD. Say it as SUDD. It means the patient has symptoms attributable to their diverticula, abdominal pain, with or without bloating, and a change in bowel habit, but no complication at all. No inflammation, no abscess, no perforation, and no bleeding. Our patient fits it well. 2 years of crampy left lower quadrant pain and bloating that eases after a bowel movement, in a colon that we now know is full of sigmoid diverticula. But it is a diagnosis of exclusion. You earn the label by ruling out the complications first. But be careful here. because SUDD overlaps heavily with irritable bowel syndrome. Both give you abdominal pain, bloating, and altered bowel habit. Both have a normal examination and normal inflammatory markers, and the presence of pouches does not prove they are the cause. Plenty of people have diverticulosis and irritable bowel syndrome at the very same time. In practice, the distinction is clinical and it is imperfect. So what matters most is what you must not do. Do not label ongoing pain as SUDD and then stop looking. New symptoms, changing symptoms, or any red flag still deserve a proper workup. Anchoring on the pouches you already know about is one of the ways a colon cancer gets missed. So what do we actually tell him to do? Start with fiber. The mechanism we built argues strongly for it. Bulkier stool, a wider lumen, lower segmentation pressures. But be honest about the evidence. The data supporting a high-fiber diet to change the course of diverticular disease are limited, not absent, limited, and most of what we have is observational. So the reasonable position is this. Recommend fiber because it is safe, it is cheap, it treats his constipation, and it has clear benefits well beyond the colon. But do not promise your patient that it will prevent diverticulitis. Recommend it honestly, so tell him what fiber will do for his bowels, and stay careful about what you promise for his colon. Now the myth. For decades, patients were told to avoid nuts, seeds, corn, and popcorn after a diagnosis of diverticulosis. The theory was that a small hard fragment could lodge in the mouth of a diverticulum and set off inflammation. It is an appealing story, and the evidence for it never held up. The data supporting avoidance are limited at best, and a large prospective cohort found no increased risk of diverticulitis or of bleeding. In fact, nut and popcorn intake trended the other way. So unless your patient tells you a specific food reliably causes them pain, do not take these foods away. It is a restriction with a real cost and no payoff. Let us put the counseling into plain words. Tell him this. You have small pouches in the wall of your colon. They are very common at your age. They are not cancer, and they do not turn into cancer. Most people who have them never have a problem from them. Then tell him precisely what to watch for. Persistent left-sided pain with a fever, or a large amount of blood in the stool. Then go through the modifiable list. More fiber, stop smoking, move more, lose weight, limit alcohol, and use less ibuprofen. And then say the part he is waiting for. No special diet, and no foods you have to give up. That last sentence is usually the one he remembers from the whole visit, so do not bury it at the end. Now the traps. First, diverticulosis is not diverticulitis. The suffix changes everything about what you do next. Second, a colonic diverticulum is a false diverticulum. It has no muscle layer in its wall, which is why it is thin and why it bleeds. Third, the pouches do not require surveillance, and they do not become malignant. Fourth, do not blame every abdominal pain on the diverticulosis you happen to find on a scan. It is common enough to be an innocent bystander. And fifth, remember the geography. Right-sided disease is the rule in Asia, and right-sided pouches account for most of the bleeding. Get those 5 right, and you will handle this finding better than most of the ward does. Back to our patient. Assessment. A 61-year-old man with a heavy and largely modifiable risk profile, found to have moderate sigmoid diverticulosis on screening colonoscopy, with 2 years of symptoms consistent with symptomatic uncomplicated diverticular disease. Plan. First, reassure him that this is common and it is not cancer. Second, treat the constipation with fiber and fluid. Third, refer him for smoking cessation. Fourth, start him on a walking program and address the weight. Fifth, substitute acetaminophen for ibuprofen where he can. Say that acetaminophen. And finally, give him clear return precautions. Let us recap the mechanism. A colonic diverticulum is an acquired herniation of mucosa and submucosa through the muscular wall of the colon. It occurs where the vasa recta penetrate that muscle, because those vascular crossings are the built-in weak points. Abnormal motility and raised intraluminal pressure supply the force. Segmentation seals the lumen into short, closed compartments. And by the law of Laplace, the narrow sigmoid converts each contraction into the highest pressures anywhere in the colon. That is why the sigmoid is nearly always the site, and the muscle never comes along, which is why the pouch is thin. Weak point plus pressure equals pouch. That is the one sentence to keep. And now the clinical numbers. Prevalence is about 10% under the age of 40 and 50 to 66% over the age of 80. About 90% of diverticula are left-sided and mostly sigmoid, except in Asia, where 75 to 85% are right-sided. Most people stay completely without symptoms. 5 to 15% will bleed, and 10 to 25% will develop diverticulitis. Symptoms without a complication is SUDD, and it overlaps with irritable bowel syndrome. and the data on fiber and on avoiding nuts and seeds are limited. So reassure first, then modify what is modifiable. Those are the figures to have ready the moment a patient asks how worried they should be. Those are the sources behind today's teaching. The definition and the pathophysiology follow the current review literature on diverticular disease. The prevalence figures and the left-sided and right-sided distribution come from published epidemiologic series, and the diet evidence comes from prospective cohort work and the systematic reviews summarized in the gastroenterology literature. The anatomy of the colon wall and the vasa recta follow standard anatomy and pathology texts. Thank you for spending this time on rounds with me. Go take another look at the next colonoscopy report that says diverticulosis. I think you will read it differently now.